So these are recent data from the group in Barcelona, Julián Panes and his group. The Rimola is a very good radiologist working in Barcelona. What they've shown us last year in gut is that if you do a dedicated MRI colonography, you will hardly need an endoscopy anymore, because there was a very good correlation between even the mucosal ulcers, let alone the transmural disease, on the MRI colonography and the endoscopic lesions that were visualized. So patients had back-to-back endoscopy and an MRI colonography. Mind you, it's probably early days. They're using a 3 Tesla machine, and these are dedicated radiologists that have been trained, probably really good to look at that. Can we extrapolate that to all centers in the world? I'm not sure at this time. I think we need more data before we can do that. But remember what I said about endoscopic healing. It's a surrogate. Well, I think with all these new techniques, we're looking at surrogates of a surrogate. So we have to be careful that we don't forget the patient level. But just to show you, I think, where these new imaging techniques are going to come aboard, and I know you guys have much more experience than we have. This is your typical Crohn's patients with ileal disease that keeps on coming back. So resection, endoscopic dilation, resection, again, strictureplasty, and then 2006, recurrent abdominal pain. And we did an ileal colonoscopy, some mild rectitis, we didn't have any urgency, no stenosis whatsoever. We said, okay, we're missing something. Small bowel follow-through, unremarkable. Well, unremarkable, I'll show you pictures, but they didn't see any stenosis on that. But April 2007, sure enough, the guy comes up to us and he said, I'm having trouble working on my aircraft because I'm getting too many abdominal cramps and I'm losing weight. Ileocolonoscopy, unremarkable. It was not having severe lesions. But then the small bowel follow-through, we went back to that a year ago, and well, the radiologists were not able to push the bowel apart in this region. And sure enough, we did a CT enterography. It was an enteroclysis. I'm sorry, you see the tube here. And you see here these lesions. And believe me, they were contrast enhanced also. We treated the patient with an anti-TNF agent because he's already seen a few other therapies, and he's doing fine ever since. I know he'll need new strictureplasties, and I don't think these are all sites of previous strictureplasty anastomosis. But if we can keep him off surgery for a while, I think that's a noble thing. And second, he was having real symptoms, but we were not just aware of that. Fistulizing disease, also very complex. I mean, if we keep on looking at a complex fistula as a mountain somewhere in the Rockies or closer by here in Vermont or whatever, we're going to fool ourselves because they're really icebergs, and you know that. And we've discovered that with MRI. You see here a horseshoe fistula in a patient that had an appearance pretty much like this one. I know I'm mixing up sexes here, but it's just for demonstration. But I wanted to show you also with this patient that, and this paper is now in press in clinical gastroenterology and hepatology, and it's been shown also from the St. Mark's group, that you do see improvement with MRI when you treat the patient with an anti-TNF agent. You see here clearly the horseshoe fistula going away. But the improvement is only there for short to mild to moderate term, so 1 year. Beyond, we don't see a lot of improvement. And bottom line message is the tracks are still there. So I think we've been overambitious as physicians, telling the surgeons, well, now we can heal fistulas with anti-TNF agents. I'm not sure. I think we can take all the inflammation out of the fistulas. I don't think we're completely healing the fistula. Final part of the talk, and then I'll leave you alone. Trough levels. There's a lot of rumor out there about trough levels. So what's going on? Well, this is a compound picture. It's a bit busy, I'm sorry, but I made about the drugs we're looking at, biologicals now in Crohn's disease and ulcerative colitis. You know that infliximab, for example, is a chimeric antibody. It's got 25% of mouse protein, and we're getting cleverer and cleverer in the bench, going to human, still artificial antibodies, but human antibodies. Now the question is, can something go wrong with this, with our own immune system? Can we recognize these proteins as aliens? Yes, we can. We're very efficient at doing so. We have 3 levels of doing so. We can form anti-mouse antibodies, right? Which probably are formed against infliximab. We can form anti-allotypic antibodies. They're directed against, for example, the Fc portion of an IgG1 fragment. Drug companies are most afraid of anti-idiotypic antibodies. Why? They're targeted at the binding region of the antibody against the target. So they're immediately impacting efficacy. These guys can impact efficacy by clearing the drug from the circulation. These guys are on the spot going to make the patient a non-responder. But I think we should a little bit leave this discussion about antibodies. What is more important for our patients is the trough levels of the drug, because for most patients, they do reflect antibody formation. Maybe not for all of them, but for most of them. This is pioneering data from Elena Maser when she was working in Gord Greenberg's group in Mount Sinai in Toronto. And you see here that there's a clear association, higher serum infliximab trough levels, higher likelihood of being in remission with infliximab. Clear association. This is cohort data, open label, but I think they're very clear. But what's going on with pharmacokinetics of anti-TNF agents? We don't really know. This is infliximab. Patients are loaded up like an Energizer bunny with infliximab when they leave the infusion clinic. Very high levels in the serum. Go back every time before a new infusion. This is a trough level every 8 weeks. Adalimumab, different picture. You see that you don't have a real trough level with adalimumab because patients are injecting every 2 weeks. And you see a little bit more of that pattern, no peaks. We don't know whether the area under the curve is important. We really don't know what that means for a patient. Do they need that peak level and that high doses initially? Actually, there's a lot to discover there. But what we are doing, if we're optimizing the therapy with increasing doses of infliximab and adalimumab, we're just bringing from the trough level in a lot of patients from down the bar, up the bar again of some sort of threshold level. Are there data in UC? Again, Mount Sinai in Toronto, Cynthia Sale, showing you that patients with antibodies to infliximab and detectable trough levels were much less likely to have a colectomy in UC. So again, a link between the trough levels and long-term or short-term outcome for patients. Do we need concomitant azathioprine? This was not my talk, but I'm just going to show you one slide just to show you that the evidence all over, and this is the evidence I could gather recently, all over the trials or cohorts is a bit mixed. You see a clear message, except for the Toronto experience, of lower trough levels. It's not always significant, but there's a trend of lower trough levels in monotherapy. We just don't know how much that translates into clinical response, but this is something we have to follow.